This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Kait Nevel. Today I'm talking to Philipp Karschnia, a resident physician at University of Munich in Germany, who's first author on a recently published paper, Association of MTHFR Polymorphisms with Leukoencephalopathy risk in primary CNS lymphoma patients treated with methotrexate-based regimens. Philipp completed this work during his postdoc fellowship at MGH. And today I am really looking forward to talking to you, Philipp, about this paper.
Yeah, thanks so much for having me.
I can't wait to get into the details of your paper some more, but before we do, can you tell the listeners what you think the most important message is from your study?
Methotrexate is certainly the backbone of any therapy for primary CNS lymphoma. We know that it often causes leukoencephalopathy, and this leukoencephalopathy may then translate into cognitive complaints of patients. And we don't really have a biomarker other than age to identify individuals at risk. And in the current study, we found that there's a common polymorphism of a gene which encodes for proteins which are involved into the methotrexate metabolism. And those polymorphisms may represent a biomarker to identify individuals at high risk to develop leukoencephalopathy following treatment with high-dose methotrexate. And we also provide evidence that this kind of polymorphism is not only associated with imaging findings, but also linked to inferior clinical outcome when compared to patients without that polymorphism. This polymorphism may really serve for a risk assessment to guide patient management when it comes to therapy with high-dose methotrexate for primary CNS lymphoma.
And building off of that, could you go into a little bit more detail about mechanistically how these polymorphisms can play a role in terms of the risk of leukoencephalopathy with methotrexate exposure? And what made you think to even look at this in the first place? What do we already know about these polymorphisms before your study?
High-dose methotrexate, as said, is the standard of care for newly diagnosed primary CNS lymphoma. And pharmacologically speaking, it's a potent antagonist of the folate pathway. And as said, besides having acute side effects, it often also causes leukoencephalopathy. And MTHFR is a gene which is encoding for protein, which is a critical regulator of folate levels within the tumor cells, but also physiological healthy cells. And MTHFR polymorphisms are pretty common. So about 70% of the healthy population, depending on race, do have polymorphisms within that MTHFR gene. And those MTHFR polymorphisms have been linked to altered metabolism of high-dose methotrexate within tumor cells, but also within physiological cells. And we know that in terms of systemic toxicities, MTHFR polymorphisms are being associated with more severe and more frequently encountered systemic toxicities, mainly including liver toxicities. So it's very tempting to speculate that polymorphisms of the MTHFR gene may also result in a higher rate of CNS toxicities or more severe CNS toxicities.
On that note, can you tell us a little bit more about the study design and who you included in study, how you identified patients?
We retrospectively identified patients which have been treated for primary CNS lymphoma at Mass General Hospital in Boston. And we identified all patients who have been treated with high-dose methotrexate as an induction to first-line chemotherapy between the years 2000 and 2022. And we excluded all patients in which we had a follow-up time of less than 6 months and who within a period of 5 years following high-dose methotrexate have received either CNS-directed radiotherapy or intrathecal chemotherapy, as both radiotherapy as well as intrathecal chemotherapy might themselves induce leukoencephalopathy and might dilute any association between a high-dose methotrexate and leukoencephalopathy. And from all those patients, we collected clinical information when we had MTHFR status available for our review. And this left us with 68 patients, most of them being Caucasian. And why I mention that here is because there are certain differences in the prevalence of MTHFR polymorphisms depending on race. And from that 68 patients, about 1/3 of them had a missense mutation in the position 1298. About somewhat more than 1/3 had a missense mutation in position 677. And only 10% of the patients did have a normal genotype, which is somewhat less than we would expect. And those 68 patients represented our study cohort.
One of the things that I found a little interesting about your study was how many patients were able to identify who had the MTHFR polymorphism mutation, assessed even. And so I was wondering if that's common practice, if MGH, or if that's something that you feel like is standard.
I don't think it's standard of care throughout the entire country or even in Europe. It's certainly not standard of care. At MGH, we indeed started to test every single patient since a couple of years because there have been publications on the association between MTHFR polymorphism and systemic toxicities, such as liver toxicities. And in those patients, it might also have therapeutic implications because we might do some accelerated leucovorin rescue and really be more careful regarding patient monitoring and follow-up. Nowadays, every newly diagnosed PCNSL patient at MGH does get testing for MTHFR mutation, but certainly not 22 years ago. That's why the number of patients in our cohort is also that low.
Sure. Can you tell us a little bit more about the outcome measures that you looked at to assess for leukoencephalopathy and what the most important findings were from those assessments?
We looked at two big things. One are radiographic findings. So we looked at the MRIs of each individual patient at baseline and 6 months following high-dose methotrexate, 1 year, 2 years, and 5 years after high-dose methotrexate. And on those MRIs, we assessed the non-tumor-bearing contralateral hemisphere and assessed whether white matter disease, depending on the severity. So either not being present at all or being very mild in nature, which we defined as less than 1/3 of the hemisphere being affected, or severe, which we define as more than 1/3 of the contralateral hemisphere being affected. And the second thing we looked at were response and survival data. So we collected data on disease response to induction chemotherapy, but also progression-free and overall survival. And what we found was that the MTHFR polymorphism, which has a missense mutation at the 1298 position, was associated with the development of leukoencephalopathy. So about 70% of patients who had this missense mutation eventually developed some kind of leukoencephalopathy, as well as with severity of leukoencephalopathy. 6 of the 9 patients who had severe leukoencephalopathy also had that genotype. We did not find any difference in disease response or progression-free survival between patients with and without the polymorphism at a median follow-up of about 10 years, but a lower overall survival in patients with that missense mutation position 1298 when tested against individuals without this genotype. And it's very tempting to speculate that the higher rate of leukoencephalopathy and the more severe leukoencephalopathy might have translated into a reduced clinical status, eventually prohibiting those patients to undergo further therapy once the tumor has progressed or recurred.
Did you include, and I can imagine this would be really hard to do retrospectively, but include any additional measures of potential impact of leukoencephalopathy in terms of like cognitive functioning and neurological function?
That's a wonderful question, and that's certainly a very important limitation. So I think that's not only a limitation for our study itself, but for a little bit for the entire field of neurotoxicity and white matter disease, right? Because we don't really have good studies in prospective cohorts to correlate white matter injury with functional and cognitive outcome. And as you pointed out, it's very hard to do this in a retrospective study. So we did not have formal neurocognitive testing available for our review. So it remains a little bit speculative whether the association between inferior survival and leukoencephalopathy and that genotype really were due to reduced cognitive function.
What do you think is next in terms of assessing this association further or understanding it better and how it may impact patients or patient treatments. And I'll add one more qualifier to that. In terms of leukoencephalopathy, we don't have great treatments, as you know, for treatment-related leukoencephalopathy. So just wondering what your thoughts are on what's next.
I think for that certain polymorphism or gene as a risk factor for leukoencephalopathy induced by high-dose methotrexate, I think it's very important to have our findings verified, both in our retrospective cohorts, but also to incorporate that kind of testing into prospective clinical trials protocols to make sure they are really valid. And as you pointed out, there are not too many strategies to mitigate symptomatic leukoencephalopathy or leukoencephalopathy at all. There's this term which has been coined as chemo brain, and there are a lot of agents out there which have been used, including CNS stimulants, drugs which are being used for memory impairment, and even bone marrow supporting agents. And beneficial effects have mainly been reported in children undergoing, for instance, whole brain radiotherapy or systemic chemotherapy or some childhood cancers. But efficacy in adults really varies across different studies. Anti-dementia drugs may work to some extent, but clinical experience is really limited. And there are also some preventive strategy on the horizon. So when I think about what is next by combining such novel therapeutic approaches for cognitive dysfunction together with our findings, I would say that patients with such an MTHFR polymorphisms scheduled to undergo high-dose methotrexate are probably the ones which you want to see enter a clinical trial, because you would think those are at high risk to eventually down the road develop cognitive complaints, and you want to match them into any trial which aims to prevent and stabilize myelin function as early as possible. So I think that would be the next step once our findings are validated.
Thank you so much. This is a really interesting paper, and I'm looking forward to seeing what's next and how this may impact future patient care and improve patient care, and able to, as you say, maybe find a way to prevent treatment-related leukoencephalopathy or lessen it based on risk factors and identify those patients who are at most risk.
This was wonderful being here, and thanks so much for letting me discuss our findings.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.